So our next speaker is Sakara Hutspardol. Sakara is a hematopathologist at Vancouver General Hospital and is the Director of Transfusion Medicine at the Vancouver Coastal Health Authority. Sakara will be speaking to us today about the utility of viscoelastic assays in trauma-induced coagulopathy. So welcome. Thank you.
Yeah, first, thank you, Dr. Kim, for the kind introduction. I actually have a question for Emily. Is that your dog that in the picture that went hiking?
No, the dog lives on the volcano.
Okay. Yeah. So thanks the organizer for the invitation to speak at the Norman Bethune Symposium today. It was a great honor. I've been a big fan of this symposium, so it's good to be here today. So we're going to switch gear from hemoglobinopathy to a little bit of coag and transfusion. I have no conflict of interest to disclose for this talk. And the overview of this talk will include, first, pathophysiology of trauma and how it's impact coagulation system, what is the definition or how to diagnose trauma-induced coagulopathy, what is the transfusion strategy in trauma, and how do we integrate the coagulation test in our transfusion management, how did it work in terms of using conventional coagulation tests or viscoelastic tests to guide your trauma resuscitation, and the last bit will be about the evidence of, comparison between conventional coagulation tests and VET. I'll just call it in a brief. So first, when you have significant or severe trauma, definitely large amount of tissue factor will be released from the tissue itself or from the endothelial cells that were damaged. So you're going to have large thrombomodulin exposure, and that's activate protein C system. Another piece is the tissue, literally TPA, like natural TPA that were released from the endothelial cells injury. But it's actually a whole blood process, to be honest, right? Because you have endothelial cells, you have red blood cells, you have white blood cell platelets and coagulation system. So thinking about this is probably more ideal if you test coagulation system as a whole. I mean, of course, you can't test endothelial injury, but you know the concept there. So, and another piece that we don't know much is the interaction between white blood cell, which tends to be high during trauma, how it interacts with platelets and endothelial cells. And many of the literature describe that, even without exsanguinous bleeding, this neutrophil, particularly neutrophil extracellular trap, can actually damage blood-brain barrier and worsening the coagulation in general for patients with traumatic brain injury. So just to go over briefly, again, we talk about large amount of soluble thrombomodulin that will bind with thrombin, activated protein C with the body cofactor protein S, and that's it inactivated factor 5 and factor 8, which is going to be even more of the issue if the patients receive unbalanced resuscitation with a lot of crystalloid or a lot of red blood cells without plasma or platelets or coagulation factors. So what is unique about trauma? So we talk about, endothelial cell damage, tissue factor, activated coagulation system. So TPA definitely activated plasmin, chop up the fibrinogen. So even the clot was formed, it's not going to be well stabilized. It will get lysed pretty rapidly and easily. And that's why antifibrinolytic agent is so important for trauma management. So in terms of strategy, how do we deal with trauma resuscitation using blood component or product? So started off with you recognize bleeding pretty early. In some high-risk group of patients, even they don't have exsanguinous, bleeding out, external bleeding, you have to keep looking for it if they don't look well. So whole body CT scan, head CT, because TBI, traumatic brain injury alone, can actually induce coagulopathy, maintain temperature, fix acidosis, give them calcium, a whole bunch of things. I mentioned tranexamic acid, which is antifibrinolytic agent that we use very commonly here in BC. BC emergency health system, whenever they pick up trauma patients, it's a protocol here that 2 grams of TXA will be given right away if they see that the patient is bleeding. So majority, I did a survey, part of it is not every patient that will have good venous access when they pick up the patient on the scene, but majority of them receive tranexamic acid before even arrive at the hospital. And then again, when they arrive at the hospital, you wanted to know that they have a coagulopathy yet or not, so you get the coagulation test done as a baseline. If it's abnormal, we fix them and then we follow up. And again, while you're waiting for the coagulation test to be available, for the result to be available, you have to start doing something. So this is just to show that the scheme of how we manage trauma here in British Columbia. We have ground ambulance and air ambulance. Our ground ambulance, I think this is different from the US. We don't have blood. Like with a paramedic who pick up patients with ground ambulance, they don't have blood. But we provide blood with a blood on board program for BC ambulance. And from May the 14th, we're going to have fibrinogen on board as well. So they get referred to the hospital. As I mentioned, get the baseline coagulation test done as soon as possible. While you're waiting for the result, they tend to receive crystalloid before the arrival. So then you start with resuscitation with blood components. So commonly you use 4 red cells for adults and then 4 plasma as well. So the key thing is you wanted to get the test result as soon as possible. Either you use the runner or you can deliver blood to the pneumatic tube. However, someone has to be there watching, making sure that the tube will be transferred to the analyzer as soon as possible. And because of this time-sensitive process, it doesn't move. Okay. Did I move too fast? Oh yeah, I'm sorry. In Europe, maybe since 1970s, 1980s, because they use more factor concentrate, they're kind of more specific in terms of they look at the test result and then they tailor down to which part of the components or product they want to be given for a trauma patient. So it's been a long-known concept in Europe that they rely on the test result and they decide what to give. So that's why viscoelastic test has been used in Europe a long time ago. In North America, in Canada, we kind of always started off with ratio-based resuscitation, 1:1:1 or 2:1:1. So the first 1 or 2 is mean red blood cell, and then you keep proportion of plasma and then platelets as well. But after you get the result back, so you switch to goal-directed treatment depends on the coagulation result. The limitation of conventional coagulation tests is, first, it wasn't designed to diagnose trauma-induced coagulopathy. INR, as you know, is for vitamin K antagonist monitoring, prolonged INR. The fact is, many studies show that if the patients arrive with INR over 1.5, they use PT ratio, 1.5 times of normal limit, that is translate to high mortality, up to 35 to 40%. So that's why we use INR as a part of our CCT guided plasma transfusion. But as you know, it wasn't designed for that. And again, if patients had direct liver injury, and that's lead to elevated INR, it doesn't mean that these patients require plasma transfusion. And many of you know that lupus can actually interfere PTT easily. And many of the guidelines use that if the PTT is more than 1.5 times of the upper normal reference range, that is the indication to give plasma. That means if you have lupus anticoagulant in your sample, then you just give plasma, unnecessary. Klaus fibrinogen method is a very good method, very reliable. However, in most labs, it takes 30 minutes to get the result back. So what is VET? So VET is a whole blood testing. So you get everything. You get red cell, you get plasma, you get platelets, fibrinogen. So draw the blood, put the blood in the cuvette, and then you add the activator. Depends on what type of test. So XTEM for ROTEM, similar to INR in a way, or INTEM, similar to APTT. So you add either tissue factor or contact factor, and then you activate the clot. So basically, two pointer here, but you can see. So most common VET test that we use is either TEC or ROTEM. Only major difference is what is rotating. So if it's a TEC, is you put the blood in the cuvette, and then the cup will be the one that's rotating, and you have a needle, the pin that stick into the blood in the cuvette. Start activator, and then once the clot started to form, then that transmission force will be detected by either electromechanical transducer or optical sensor. That's the resistance of the clot. So you can see on the left-hand side here, so the time it takes from the moment you add the clot activator for the first clot to form is about 2 millimeters, like height of the clot, and that we call clot time or R time in TEC. And then you keep looking and see the clot kinetics or clot firmness or strength, just to see. You can put a benchmark and see, okay, you want to see how high the clot curve is at 5 minutes or 10 minutes or whatsoever. And we have a reference value that what is normal, what is abnormal. So once the clot reaches its maximum clot firmness, that's a report number. And then physiologically, right, if you wait longer, then the clot will start to lyse by our fibrinolytic system. And you're just measuring this number compared to the reference or normal reference. Again, VGH use ROTEM delta, the one up top here. Then you have TEC, that is the original one in 1948. And then the most recent version is TEC 6S that I believe it's used at St. Paul. So the benefit of it is you get to visualize the clot curve, and our clinicians, they love it. They really like to see the curve themselves rather than reading the number. Where it should be, right? So ideally, it should be close to the patient or close to the physician as much as possible. But the reason why we decide to put our ROTEM in the lab is just because of the validation, accreditation, and quality control. It doesn't mean that we don't trust clinical, but it just started that way. So how do we interpret and integrate this result into our transfusion management? So first part is how long it takes for the clot to form. That represents a coagulation factor. If the patient is on high-dose anticoagulant, that can also prolong clot time. And then you look at the amplitude, kinetics, and also firmness. So the firmness part of the strength represents platelets, fibrinogen, and factor 13. And then, of course, the clot lysis is relying on the fibrinolytic system. So here's the example. XTEM CT here is normal, so that means you don't have to give plasma. A10 is low. However, you know that the amplitude of the clot or kinetics represent platelets and fibrinogen. So when you interpret this, you have to interpret XTEM and FIBTEM in parallel. So FIBTEM is literally XTEM, but you add something to remove or inhibit platelets effect, which is cytokeratin D. So when you interpret, you have to read both curve or numbers in parallel. So in this case, XTEM A10 is low, FIBTEM A10 is also low, and then your decision is to give fibrinogen. This is an example of someone who had bleeding and increased fibrinolysis. So the treatment will be give them tranexamic acid. So we implemented a ROTEM guided transfusion management algorithm at VGH since 2016, thanks to Dr. Trudeau, one of our anesthesiologists who led this project together with Dr. Tyler Smith. 4 columns here. So first column, X-TEM, A10 is low. However, 5-TEM is also low, and the decision should be giving fibrinogen treatment. The next one, just to show that X-TEM, A10 is low, but 5-TEM is normal, then you give platelets. The third one is it took longer for the clot to form, then you need clotting factor, which is plasma, and the last one is tranexamic acid. You can give additional dose. So this study was conducted at VGH in 2024. It's not a comparison, basically, in terms of, we didn't do like randomized control trial to 2 groups, but we actually wanted to see that after we have ROTEM, how our trauma surgeons, ED physician, anesthesiologists, use our test. So we look at the patients who had massive hemorrhage protocol activated from 2022 to 2024, and we picked the cases that had both tests performed simultaneously. So the middle column is the group that had only abnormal ROTEM, but CCT was like pristine. So in terms of abnormalities, majority of them are low 5-TEM, and then you had a little bit of low A10, prolonged CT here and there, but majority is low 5-TEM. So when we look at how does it impact the transfusion, what I see, it depends on how you interpret the data, right? So you can see that they receive almost 1-to-1 still. Red cell 10, plasma 10, platelets 3, and then fibrinogen. Of course, limitation is retrospective, is observational, no comparison, and really depends on how severe your trauma population is, which is, I believe it is. VGH is a level 1 trauma center. For patients that had low 5-TEM alone, they're still receiving a lot of red cell and plasma and almost 1-to-1. It didn't change. So what I'm seeing is, when the situation is so critical and it's so chaotic, everyone is nervous, they kept going. And when we wanted to see that abnormal ROTEM and abnormal CCT, how did it translate to the mortality outcome? And we found that the patient with abnormal ROTEM didn't have worse outcome in terms of mortality, but the one that had abnormal CCT on arrival did have worse outcome. So the summary of this study is, for our ROTEM test, it's more sensitive. And patients still receive a lot of blood product all across the board. Patients with abnormal CCT had, higher death, but not the group that had abnormal ROTEM alone. So what is the evidence out there? The one that highlighted in yellow is the one that, according to the systematic review, that if you use VET, it could improve the outcome. But you can see that even, the Mohammed one is only for young patients, so it's not for all patients. So patients' population do matter, which one will benefit from what kind of approach. If you haven't read this, Dr. Levy wrote a very good illustrative article. So we're going to focus just on 2 RCT. So one is itactic RCT that published in 2021. So it did show that there is no difference in mortality or massive transfusion between the group that used VET, either TEC6S or ROTEM to guide transfusion management, compared to CCT, and the group that used VET is actually received more platelets and fibrinogen. So another one is Gonzalez, and I think this was the one that led to VGH implementing the ROTEM. So this one showed improved survival and less plasma and platelets used in the group that guided by TEC. Cost-wise, VGH, we're quite cheap. We only had X-TEM and 5-TEM. We didn't implement in-TEM or hep-TEM. So we actually half price, talking half price with the cartridge-based ROTEM Sigma or 6S TEC at the moment. But you can see cost per test, $46 per test, compared to CCT, which is altogether less than $1. And now it's very popular. at VGH that ICU love it, trauma love it, OR love it. Our ROTEM utilization in terms of number went skyrocket in the past 2 years. So the summary here is VET is sensitive, clinical validation is the key. People who interpret the result really need to know how to translate into their transition management. It's quite sensitive, so it could lead to more transfusion. The evidence is mixed, whether it's better than CCT or not. And then if, after all, you decide to implement it, then test location, patient's population, who you allow or you should encourage them to use VET. I think that is the key. And we are performing ongoing clinical validation in ICU, in the OR, just to see that how our clinicians use the test and how does it impact the transfusion management. Thank you.
Great talk, a great tour de force, putting all the viscoelastic testing, very thoughtful and really quite well done. In the US, tranexamic acid is only given by the time you see fibrinolysis on the tracing. If you're giving it then, it's too late. I love the fact that you guys are giving it in the field, critical to early intervention, and all the complexities of what plasmin does in creating all the coagulopathic chaos that occurs in traumatic injury. A couple of points is that your maximal clot firmness is really fibrinogen, and even though it's used as platelet transfusion algorithms, and the biggest weakness and link in the chain is our ability to measure platelet function. The Verify Now, which is a great test, it's red cell dependent, but like you said, the fact that you have a whole blood assay looking at red cells and white cells is really a kind of clinically relevant scenario, because in a clinical, consideration, it's all pretty much a totality. One thing that, just to question what you said, 2 grams, the CRASH 2 study, which I actually wrote the editorial for years ago, it's a gram load and a gram over 8 hours. So nobody really, are you giving 2 grams as a bolus, or you give it 1 gram? Do you know in the field? Because it makes more sense to give a 1 gram initially. And we did some PK on that some ages ago. So
very good point. 2 grams all along, and I'm part of the provincial massive hemorrhage protocol as well. So people are asking, because if you really rely on a clinical trial, right, it's exactly the way that you described, at 1 gram bolus and then 1 gram infusion, and that's also similar to the women's trial as well. But again, we think about practicality, because so that's why we implement 2 grams for all. But that is a very good point, and many people are asking, is that not too high? But we think it's better to at least have it, and then people will not forgotten not to give it. Yeah.
So one quick comment is that the trauma surgeons, Gene Moore and the group in Denver, basically are part of the US perspective of fibrinolytic shutdown. And I think that's really a misnomer, because at that last stage, everything is a bit amok. But great presentation, a nice sort of tour de force. Thank you.
Very good point, because I prepare so much just to review the coagulation. I'm talking in front of CBR scientists. Everyone said it's significant increase of the PI1, which is supposed to shut down fibrinolysis, right? So I think it's a matter of balance. Which one is more potent? But you're absolutely right, yeah. Thank you.